Well, good evening, everyone. It's 7:30 on Wednesday evening. Thank you very much for joining. If someone can just say whether or not they can hear me in the chat. Lovely, thanks, Matt. Welcome. Just had a little look in the chat there. We've got a truly international audience this evening, so welcome along to those of you. I can see some familiar faces in the crowd. Welcome back. Welcome if it's your first time. We hope that tonight will be interesting for you. So Eastbourne, fantastic. The Sunshine Coast, the Gold Coast of the UK, and yeah, absolutely. I think New Zealand wins at the moment. Although the Isle of Arran is very, very pretty. So welcome along. Good to see you all. So we are STC Training Solutions. We are a pre-hospital care training provider based in Aylesbury, just outside, well, in the southeast of England. We do predominantly FREC 3 and FREC 4 training. We had this idea of doing some interactive webinars last year during COVID, and of course they've caught on. So here we are coming towards the end of our most recent series. These videos have been aimed at those of you going through the FREC pathway, predominantly those of you that are looking to upskill to FREC 4, and those of you that have FREC 4 or FREC 5 and want to just do some CPD. So far feedback's been good. We're on the second part tonight of our little ECG mini series. This is very basics of ECG, aimed at those of you going through FREC 4. It's at the level you need to be at to pass the ECG exam on your FREC 4 course, plus a few extra little bits that might help you in real life. So if you are interested in ECGs, we did a whole series at the very beginning of COVID, back beginning of, well, end of spring, beginning of summer last year. They're on our website, on the STC trainingsolutions.co.uk, and then go to CPD Home. You can see our ECG series from previously. That's going to be remade in the new year. So if that's something that interests you, then do look out for updates on our social media. Those of you that haven't met me before, my name's Innes. I'm a paramedic practitioner by trade. I work in a GP surgery in the southeast. I used to work for London Ambulance Service full-time, now bank, and also bank with South Central Ambulance Service. So just trying to keep up to date with everything that's going on. If you have any questions as we go through this evening, then please do feel free to pop them in the chat. We want tonight to be as interactive as possible. ECGs are kind of my main area of interest. So if there's anything that about ECGs you want to talk about, then please feel free to do so. And we'll just give everyone a couple of minutes just to come in. Those of you that are joining, the numbers have just gone up a little bit. So welcome, you haven't missed anything yet. Settle in, get comfortable. Tonight's session should last about 40-45 minutes with a quiz at the end, of course. So as usual, the quiz at the end, the winner will get 10% off any course of their choosing. Yeah, hopefully you can join us for that. So good, right, welcome. Let's have a look then. As I say, we are a pre-hospital care training provider. We do have some courses coming up in the near future. Not many FREC 3 spaces left at the moment. It's been very, very popular. So FREC 3s, if you do want to do one this year, we do have a space left on our 20th of November course, so a bit later, 10 days time. Starts on a Saturday, whoops. There we go, let me just pause that. If you want to join us on the 20th of November, 5 days, it's over 3 weekends, you can come and do that, just 295. Next weekday course is now January. All weekday courses between now and Christmas are full. FREC 4, if you're interested in upskilling to FREC 4, there is one space remaining on the Monday to Friday course starting on the 22nd of November, so get in there if you do want that, just 395. If you want to do it over weekends, the next one with space is now the 8th of January. ILS on the 12th of December, in just over a month. If you need your annual ILS for FREC 4 or FREC 5, do come and join us then. It's me teaching that one, and also I'll be teaching the SARM course on the 18th and 19th of December if anyone is upskilling their FREC 4. It's just £150 and a really good weekend, actually, so do come along for that. That's enough of the plug. So let's have a look at tonight. So what have we done so far? The series so far covered CPD requirements, which, as those of you that have been following us will know, that's going to be remade because the CPD requirements changed recently for FREC 3 and FREC 4. We've covered some anatomy and physiology. We've covered common pathophysiology over a few different episodes. We've talked about maternity care. We've talked about patient assessment, about paediatric assessment in particular. Sepsis, we've done oxygen and Entonox guidelines a couple of weeks ago. We're on the second of a two-part series on ECG Basics. The last one went out last week and is available to view on our website if you are interested in catching up on that. ILS next week, and then we'll finish off this series with SARM medications. That will be it then until probably we're looking at February for our next series. So that will go live in February. So that will be it for Christmas and New Year anyway. So what's tonight? Atrial fibrillation, premature ventricular complexes, cardiac arrest rhythms, ST elevation, myocardial infarction, or the STEMI, and then other signs of ischemia. So we're going to go through that tonight. Won't take long to get through the teaching material this evening. We do have an 8-question quiz at the end. As I say, the winner will take a 10% discount off any course. We will honour that against our upcoming FREC 5 course, which is due to start in May. So if any of you are interested in FREC 5, then keep an eye on our website. There's a page on there to register interest, and we'll keep that up to date as we go through the approval. Tonight we'd like to be interactive. Charlotte's around, she's in the chat, so if you've got any questions we go along, throw them in the chat. Charlotte will answer, or I will answer when we come to an actual pause. If you think of something afterwards, then do drop us an email, text, tweets, carrier pigeon, whatever you want, and we'll do our best to answer that. And of course we use Mentimeter. So Mentimeter, for those of you that haven't used it before, is an interactive tool for getting kind of answers on the screen. So you'll see how it works very, very shortly. Yes, there is a certificate available. You'll have to fill out the link. Charlotte will put a link in at the end for the CPD certificate. Okay, recommended reading for anything ECGs is the book in the middle, really, the 12-lead ECG Art of Interpretation. It's available to buy from our website with free delivery, and we are keeping on Amazon if anyone wants one of those. Otherwise, for anything to do with FREC, then do look at Ambulance Care Essentials or Ambulance Care Practice. They are the core textbooks for FREC 3 and FREC 4, respectively. So if you'd like a copy of either of those, we also sell those too, again, free delivery. Okay, let's go to Mentimeter then. Let's have a little go with that first of all. So I'll bring up the screen. If you grab your phones, go to menti.com and enter the code 20403003. And this is just a blast back to last week. Have a look at the rhythm on the screen and tell me which best describes this rhythm, maybe C or D. Sinus bradycardia, normal sinus rhythm, sinus tachycardia, or supraventricular tachycardia. Which is it? So 20403003 at menti.com, and that will allow you to answer the question. When enough of you have answered, I'll pop up the quiz. It's around 50 of you tonight, so let's see if we can get half of you on the quiz. So A, B, C, or D, which best describes this rhythm? Sinus brady, normal, sinus tachy, or supraventricular tachycardia, SVT? Lovely. Let's see where everyone seems to be going. Good. Nobody's saying SVT. A couple of you saying sinus brady, a couple of you saying sinus tachy, the vast majority of saying normal sinus rhythm, which it absolutely is. Well done, perfect. So what makes normal sinus rhythm? It's a rate of 60 to 100, which we have there. So 300 divided by the number of big squares between each R wave. So if you do that, it works out to be about 75, which is perfect. It looks regular. There's P waves before each QRS complex. The QRS is nice and narrow, and the T wave occurs within a reasonable amount of time. So absolutely normal sinus rhythm. Well done to those of you that selected that. Okay, let's have a go back then. So tonight, first thing we're going to talk about atrial fibrillation. What is atrial fibrillation? Okay, so the top of the heart, the two atrial chambers are of course separated from the two ventricles, the two lower chambers of the heart. Okay, the purpose of the atria are to contract and to squeeze blood into the ventricles in order to pre-fill the ventricles. The reason they do that, cardiac output is most effective if you stretch the ventricles before they actually start to contract. If you fill those ventricles to bursting with blood, when the valve closes, when the ventricles contract, the most amount of blood is going to be ejected through the respective arteries. Okay. And that's the way the heart works most efficiently. So atria contract, pre-fill the ventricles, ventricles contract, and then the cycle repeats. And the whole electrical conduction system is in place to allow that to happen. If you don't know what the electrical conduction system does, or if you don't understand, flick back to last week, have a revise of that, and then come back and watch this one again. So the SA node is in charge. The SA node fires in health on the picture on your left-hand side. The SA node fires, electrical signal travels through the internodal pathways to the AV node, where it's held onto for 120 to 200 milliseconds before releasing down the bundle of His and the bundle branches to allow ventricular contraction. If we didn't have that gap, the atria would contract at the same time as the ventricles and blood would go everywhere, but it wouldn't particularly travel in the direction we want it to. So in atrial fibrillation, what happens? So the SA node effectively loses control. Now it's either a defect with the SA node, or more commonly, actually, it's an area of excitable myocytes within the atria that start taking over. They get a bit big for their boots. So the SA node is the boss of the shop floor, and then you've got a bit of a loud mouth in the corner that starts shouting louder than the boss is, and everybody starts listening to the loud mouth. And in effect, that's what atrial fibrillation is. You get erratic impulses, you get electrical signals being generated from spaces other than the SA nodes within the atria. Now, when they occur kind of without the nervous system control that the SA node has, of course, they tend to be quite fast, they tend to be quite irregular, they tend to be quite erratic. Now, those electrical signals will still travel through the internodal pathways. The internodal pathways aren't exclusive to the SA node. If you send any electricity to them, they will conduct it, that's their job, and they will conduct it down to the AV node, where that signal will be held onto, provided the AV node is working properly, and the signal will be transferred down to the ventricles. So of course it will cause ventricular contraction. But if those electrical signals are arriving at the AV nodes in a fast and uncoordinated fashion, then of course the ventricular output is going to be fast and uncoordinated. And you can see how that translates into the electrical readouts in the little boxes above the heart. So the left side of the picture, you've got your normal ECG, and you can see the P wave, the QRS complex, as we'd expect to see. On the right-hand side of the screen, you can see in the little box there the difference in atrial fibrillation. So those electrical signals being generated elsewhere in the atria, apart from the SA node, have that erratic look. They have that fibrillation. The fibrillation just means a wobbly line, basically. And if you look there, you can see a wobbly baseline. You can see a relatively fast rate. In the box on the left, you can only see 2 QRS complexes. In the box on the right, you can see 5. So that tells you that the rate is faster. And you can also see that the distance between the R waves is irregular. So we can say that's an irregular rhythm. So it's a fast and irregular rhythm with a wobbly baseline. Now notice that you can't see within that any true P waves. There are some things in there that look like they might be P waves, but they're not. Okay, that is just an underlying fibrillation. Okay, so atrial fibrillation, the keys to spotting atrial fibrillation are an irregular rate, generally slightly fast, and a wobbly baseline of an underlying fibrillation rhythm with QRSs kind of popping out of it. So that's what's going on. That is atrial fibrillation. Okay, this is what it looks like if you were just to print out a lead 2. Can you see there the R waves are relatively close together. They're quite fast, and the distances between them is changing. So that's an irregular, fast, irregular rhythm with a wobbly baseline. You can see that kind of irregular fibrillation going on. No discernible P waves. That is diagnostic of atrial fibrillation. What do we do about it? Not a lot pre-hospitally. It's not a major emergency. Fast AF can be, so atrial fibrillation over 100. So when we get to kind of 140, 150, 160, we tend to get a little bit more nervous about atrial fibrillation because the chance of them throwing clots off is heightened. The reason we worry about atrial fibrillation is generally what happens when the atria aren't contracting properly is that blood comes to a standstill within the atria, particularly the left atrium. Okay, there's a particular point just behind the valve here in the left atrium, where blood actually pools in atrial fibrillation. And when blood comes to a standstill, it clots. So if you have clots forming in the left atrium, there's only one way they're going to go. They're going to go into the left ventricle, out through the aorta, and then centrifugal force is generally going to carry them up one of the carotid arteries into the brain and cause strokes. So that's why we worry about, or why we don't worry, but that's why we want to treat atrial fibrillation. We don't necessarily worry about AF when we're out there seeing patients, but if it's the first time they've come across, or they're not known to have an irregular heartbeat, they're not known to have AF, then absolutely we should be referring them on to someone that can medicate them, because we need to thin their blood. We put them on, in the olden days it was always warfarin, but now we use the novel anticoagulants such as apixaban, rivaroxaban, which are much easier to manage. So that's atrial fibrillation in a nutshell. That's all you need to know for FREC 4. It's what's basically going on underneath and how to recognize it. And it's that fast, irregular, underlying wobbly line. So premature ventricular contraction. What is it? PVC is effectively an irritable bit of myocardium, again, in much the same way as atrial fibrillation, but it's causing the ventricles to contract. So rather than this being a problem up in the atria, this is now a problem down in the ventricle. Now, I say problem in the loosest possible term because everybody has PVCs. In a normal day, most adults have between 10 and 20 PVCs. That's absolutely normal, okay? Sometimes when you get that feeling of your heart missing a beat, quite literally it is missing a beat, that's where the saying comes from, and it's because you've had a premature ventricular contraction. And what that just basically means is the ventricles contract before they were supposed to. And often the ventricle isn't filled with blood, so often that PVC doesn't produce a pulse. So when we say your heart's missed a beat, it literally has. Okay. So you can see here on the rhythm, you've got a P wave, you've got a QRS complex and a T wave. This looks all like it's going to be nice and normal. And then just after this T wave, you've got something big, broad and bizarre. They're the words I used to describe that. The person that taught me ECGs was big, broad and bizarre. And I remember them saying, use that to remind it. So whenever I think of PVCs, I think of the person that taught me ECGs in the very beginning, being big, broad and bizarre. So that's what it is. So if you look along an ECG rhythm strip and you see a rhythm that looks basically normal, but every now and again you've got something big, broad and bizarre, it's a premature ventricular contraction. Now they're not dangerous, provided they're not happening kind of, every other beat, as a name called by Gemini. Then you potentially have because if they're not producing a pulse, don't forget the heart is missing a beat every other beat. So ultimately the cardiac output's going to drop, blood pressure's going to drop, and the patient's going to become symptomatic. So provided it's not happening all the time, PVCs are benign and we don't worry about them. If you do an ECG on a patient or you do a rhythm strip on a patient and you see loads of them, then absolutely it's worth mentioning. So and may well warrant a trip into A&E to have it investigated. Common causes of ridiculous numbers of PVCs are just simply electrolyte imbalances, which can be easily fixed. So definitely worth following up with those. So big, broad and bizarre, you can see there. So what's actually going on, it's an excitable part of myocyte in one of the ventricles, and much the same way as atrial fibrillation, whereas atrial fibrillation is going all the time, PVCs are just a one-off or every now and again. And it's just somebody shouting louder than the AV node in that case, isn't it? The AV node controls the ventricles. If somebody down south in the circuit shouts a bit louder and the ventricles respond, then of course we're going to see the premature ventricular contraction. So Gary, good question. Does it only show on lead 2? No, it shows on all leads. You'll see PVCs across all leads. They don't look big, broad and bizarre necessarily in every lead, but it will look different from the kind of the beat beforehand and the beat after. But no, they appear in every lead. We use lead 2 in these training sessions because at FREC 4 you're only really taught to interpret lead 2. But as you go on with your ECG knowledge, you'll realise that there are 11 other leads to look at, and of course they are. So ectopic beat, exactly, Elizabeth. That's so ectopic beat is another way of saying premature ventricular contraction. It's also known as premature ventricular complex. It's also known as ventricular ectopy. Okay, they've all got loads of names that all mean the same thing, but absolutely ectopic beat. The only thing with ectopic beats is it can get confusing because we talk about atrial ectopics and ventricular ectopics, but again, that's something you can learn about at another time. It's certainly not covered on the FREC 4 syllabus. But PVCs you'd be expected to pick out if you were to see those. So cardiac arrest rhythms, we mentioned last week. Somebody asked whether we were going to cover those. Here they are. So the cardiac arrest rhythms, there are 4, aren't there? So you've got 2 shockable rhythms. We've got ventricular fibrillation, top left, and we've got ventricular tachycardia, bottom right. What's going on? So this word fibrillation we've seen already this evening in atrial fibrillation. Fibrillation just means a kind of wobbly baseline. Okay. Fibrillation effectively, if you imagine the heart being jelly on a plate, okay? So you walk around, wibble wobble, jelly on a plate. Absolutely, that's what the heart looks like in ventricular fibrillation. It's also described, I quite like, as a bag of worms. Just imagine what a bag of worms would look like. So many questions as to why you'd have a bag of worms, but that's what the heart looks like. It's effectively quivering. It's a quivering mess. Now the word fibrillation should sound familiar to you because we talk about defibrillators, don't we? So the defibrillator is going to stop the fibrillation. So this obviously is going to be one of the reasons when we're going to use a defibrillator. When we have ventricular fibrillation, we're absolutely not going to use it when we have atrial fibrillation. Atrial fibrillation is a rhythm that a lot of elder patients have, and it is a normal variant for them. Provided it's medicated, it's not a problem. They get on with life. We certainly don't need to be shocking them to try and put them back into normal sinus rhythm. It's not going to work. So ventricular fibrillation, on the other hand, though, is one of the cardiac arrest rhythms. These patients won't be conscious, or if they are, only for a few seconds. They won't be breathing properly, and they're not going to have palpable pulses. So they are effectively in cardiac arrest, aren't they? The heart isn't beating with any coordination. So the correct treatment for this is to shock as soon as you have a defibrillator available, and then to start your BLS algorithm. Okay. So what's going on is it's uncoordinated electrical activity across the whole heart. So rather than this just being in the atria, causing atrial fibrillation, where you still have coordinated ventricular output, you have no coordination to your ventricles whatsoever. You just have a quivering mess. Okay. Ventricular tachycardia, on the other hand, is where the ventricles are receiving a signal from somewhere outside of the AV nodes generally. And that signal is quite fast. So you can see here, this is effectively, VT is effectively QRS complex after QRS complex after QRS complex, back to back to back to back. If you imagine the heart trying to beat that quickly, it's not going to pre-fill, so you're not going to have any outflow. So effectively, VT the heart is beating. If you looked under ultrasound, you would be able to see the heart is beating, but it will be beating too quickly to produce a pulse. So of course, that patient without a pulse will soon stop breathing. If they're not breathing properly and you can't feel a pulse, they are a cardiac arrest patient. We are going to shock VT. We use the defibrillator effectively as a cardioverter. So what we're actually going to do, rather than defibrillating, we are cardioverting, DC cardioversion. We're going to stun the heart. We depolarize all the myocytes in one go, in both cases, VF and VT. We stun the heart, so it stops for a split second, in the vain hope that the natural pacemaker, the SA node, takes over again, and you get something resembling normal sinus rhythm. That's the hope. Okay, it does happen if you're there soon enough. Obviously, the longer the patients have been in VF and VT, the less likely you are to actually have a good outcome. Ways to remember this. Somebody on one of our FREC 4 courses actually came up with this, which I really like. VF is very funny, all over the place, and VT is very tidy. There's coordination to it. So it's completely uncoordinated VF. If it is coordinated, and it looks like that kind of sawtooth pattern, that zigzag, it is VT. Now, bear in mind, the more you learn about VT, the more you realize it's not quite that straightforward. You have two types: monomorphic VT, which is what you see there, which is every VT beat effectively is the same shape, versus polymorphic, which is where they are different shapes. And it's very, very difficult, even as an experienced paramedic, I still find it difficult sometimes to differentiate between a good course VF, patient that's just gone into VF, versus a patient that's in polymorphic VT. Does it matter? No, because the treatment's the same. Okay, if you think it's VT, you're still going to shock it anyway. The only difference between VF and VT is you feel for a pulse before you shock a VT, because it is possible to have a pulse in VT. Okay, so it depends on the speed and it depends on a lot of factors. I've been caught out. This is a learning point. I've been sitting, having a cup of tea and a couple of bourbon biscuits with a patient, getting their backstory before I realised that they were in VT. So patients can look very well and be in really, really unstable rhythms. The look I gave my crewmate, believe me, when I felt her pulse and went, that's abnormal. And then we put the leads on and suddenly realised we'd been sitting there chatting away for 10 to 15 minutes and our patient's in a peri-arrest cardiac arrest rhythm. But there you go, you wouldn't have known it. So patients can look exceptionally well in VT. Obviously, if you turn up first on scene, you've got a patient that's unconscious, not breathing normally, clearly, then the VT is going to be a cardiac arrest rhythm. We feel for a pulse, just double check there is no output, and we shock it. If there is a pulse, we don't shock it. Okay, that requires kind of sedation and a little bit more finesse to the cardioversion rather than just whacking 360 joules. Okay, good. So they're the two shockable rhythms. We of course then have two non-shockable rhythms, don't we? So everybody knows asystole, flatline. That's the one that everybody on casualty always shocks. But clearly, I've just told you that defibrillators defibrillate. Okay, so they stop fibrillation. They also cardiovert VT very well, but VT arrests are relatively few and far between. So cardiac asystole is effectively what we're putting the heart into when we defibrillate it. So if we shock a patient in VF, we are effectively putting them into asystole in the hope that the natural SA node pacemaker takes over again. So if the patient's already in asystole, you're going to do absolutely nothing by shocking them. So there is no point. Just don't do it. So some questions coming in. So do automatic AEDs sense pulse and VT? No, they don't. VT confuses most AEDs, okay, including LifePak 15s. All right. When you're using a LifePak 15 in automatic mode, you've got a patient in VT arrest. It's 50-50 which way it goes. It really doesn't know what to do. More often than not, it says no shock advised. Okay. Now, if you're using an AED and you're only trained in AED use, there's nothing you can do about that. VT arrests, as I say, few and far between. But if you are trained in manual mode, that's when you need to step in and override the machine, don't you? So even if you are using automatic mode, if you've got a screen, you can see that it's VT. The machine is saying no shock advised. You just need to get on and have the confidence to say shock. But you do need to make sure that you're doing the right thing if you're trained in manual mode, because clearly sometimes the machine is saying no shock advised because it really isn't VT. But that's all part of kind of knowing your limitations. But if it says no shock advised and you follow it, that's okay, isn't it? So but yes, it does confuse. The AEDs do get confused by VT, but thankfully it's rare. So would an AED shock a VT with a pulse? I've not seen it that way around. I've had to when I've turned up in AEDs, we've been using AEDs, and we have had VT arrest and it said no shock advised, and so I've had to do it the other way around. I've never had it where it's been saying shock advised and actually they have a pulse. But then again, you've got to think if they had a pulse, you wouldn't necessarily put the AED on, would you? Because you know, if you're turning up to someone that's conscious, you're not, your first thought probably isn't putting the pads on. But it's one of those things. There's no clear answer there, unfortunately. When this is why FREC 4, you're trained on manual mode. If you recognise a VT and they don't have a pulse and the machine's not wanting to shock it, if you're confident, off you go, shock it. So it's the right thing to do. So the final cardiac arrest rhythm is really the catch-all, isn't it? It's pulseless electrical activity, PEA. Probably the most common arrest rhythm, isn't it? Certainly from hypoxic and hypovolemic causes, I certainly seem to turn up to most of my cardiac arrests I turn up to seem to be PEA. So you've got I mean, the name says it all. It's pulseless, so there's no pulse output, but we have some form of coordinated electrical activity on the screen. So we have recognizable complexes, albeit the example I've given you here is a little bit slow, a little bit wide. Doesn't look completely normal, but it is a recognizable electrical complex. If that patient didn't have an output, if there was no palpable pulse, then we would call that PEA. But on the flip side of that, if you saw that rhythm on the screen and the patient did have a pulse, we would probably just call that sinus bradycardia, wouldn't we? Although I can't see P waves, we would just call that a bradycardia of some sort. So that's all that pulse electrical activity is. So there is electrical activity going on in the heart, but it's not producing a pulse. It's most commonly caused by hypoxia or hypovolemia, so patients that have run out of oxygen or run out of blood. It certainly seems to be the most common cardiac arrest rhythm. The causes of the shockable rhythms tend to be cardiac in nature, so you find most patients that have big old MIs tend to go into VF or VT, more so VF. Asystole, rare to go from normal sinus rhythm into asystole. Generally that doesn't happen. You normally progress through one of the others first. But that's not to say that whenever you turn up and you do an asystolic cardiac arrest, it's absolutely going to be, you know, that's the end. I've had successful outcomes from an asystolic arrest, but again, fewer and farther between. So that's your 4 cardiac arrest rhythms. Okay. Talk about some other bits here. So ST elevation MI is a FREC 4, you need to be able to spot ST elevation. What do we mean by that? Okay, if you flick back to last week, we looked at all the different waves. You've got your P wave, your QRS complex, and your T wave. This flat section between the end of the S wave and the beginning of the T wave is known as your ST segment. That makes sense. When that ST segment is elevated, we call it ST elevation. If the patient presents with symptoms characteristic of a heart attack, we call it an ST elevation MI, myocardial infarction. That's what we mean by STEMI. The picture on the right here I've put in just because it looks much more like this normally. You get that bit of a tick shape. So rather than the QRS complex coming back to baseline and then the ST elevation kind of sticking up in the air like that, it tends to be much more of a sloping shape like this, and the T wave effectively comes off the end of the QRS complex. So that shape that you see on the right hand side is much more characteristic of STEMI in the inferior and lateral leads. Anyway, we'll look at some ECGs in a minute. So that is what we mean by ST elevation. As I say, in a patient that presents with symptoms that could be a heart attack, if you see ST elevation in more than one lead, we're going to call it a STEMI, a ST elevation MI. That is diagnostic of heart attack. And these patients go to the primary, the PCI labs, primary PCI labs. So what do we need to call something a STEMI? We need, it's slightly different between men and women, depending on which lead you're looking at. In the inferior leads, remember these are the bottom ones here, so leads 2, 3, and AVF. They are the inferior leads. These views are looking at the bottom of the heart. We need more than 1 millimeter of ST elevation in 2 consecutive leads. So in effect, that means 2 and 3, or 3 and AVF. Okay, so technically 2 and AVF wouldn't be correct, but I'm not necessarily going to ignore that. So in any 2 leads in the inferior section, if you get more than 1 mil of ST elevation, absolutely call it a STEMI. In the lateral leads, same rules. So if you see more than 1 mil of ST elevation, then we are going to call it a STEMI. So question just coming in there. So did you say in more than 1 lead? Yes. So the STEMI criteria for all the cath labs is to have in 2 consecutive leads, 2 or more. So if you had just ST elevation in 1 lead, you wouldn't be able to call it a STEMI, okay? It would still be worth investigating, but we wouldn't necessarily go direct to the cath lab, if that makes sense, Stephen. So you need it in 2 consecutive leads, more than 1 lead, for it to be called a STEMI. And that's the same in the lateral leads. You need more than 1 mil of ST elevation in 2 consecutive leads to call that a lateral STEMI. We're looking at the left side of the heart in those leads. And the anterior leads, which of course include the 2 septal leads. So these 4 leads here in the middle are the anterior view. So it's slightly different between men and women. Okay, so we had so in men we need more than 2 mil, just because men sometimes have what's called high takeoff or benign early repolarization in the anterior leads, which means that their ST segments can be kind of a mil high anyway, which is normal variant. So in men, we need to see more than 2 mil of ST elevation in 2 consecutive leads, so either V1 and V2, V2 and V3, V3 and V4, etc. In women, we only need to see 1.5 mil. That's because generally their ST segments are isoelectric. In health, in men, it's not uncommon, as I say, to get that early repolarization going on. Messages on Facebook saying 8:30 start time. Hopefully not. I wonder if that's a setting somewhere. If Charlotte could look into that, that'd be great. Perfect. Okay. So that's what you need to call it a STEMI. So it's worth, we'll put these slides up on our website. It's worth printing that one off if that's any use to you. So we talked about ST elevation. You may also hear the term, say Matt, thank you. You got the reminder. Okay. Okay. I don't know what's going on there then, Peter. Okay, fab. So we've heard the term ST elevation. This isn't taught necessarily on the FREC 4 syllabus, but it's useful to know that you can also get ST depression. And ST depression can be a sign of ischemia. So ST elevation is generally considered to be infarct, so where the ST segment rises. Infarct is death. Ischemia is just lack of oxygen. So ST depression, which you can see here, where the ST segment is below the isoelectric line. Remember that the isoelectric line is this flat bit leading up to the P wave, and also after the T wave. So that's where we expect everything to be running from, as 0. If your ST segment is below that, it's ST depression. If your ST segment is above that, then it's ST elevation. Okay. ST depression means ischemia. ST depression means ischemia. ST elevation means infarct. You can also describe your ST segments, so upsloping, downsloping, and horizontally. I mean, that's just worth knowing. There's some good CPD there if you want to have a little read into which is best, what it all means. But generally speaking, ST depression, if you see it, means the heart muscle isn't getting enough oxygen. If you want to go back and look at our full ECG series, if this is something that interests you, then it is worth noting that if you see ST depression in your anterior leads, that can be a sign of posterior MI. Now, on the FREC 4 course, you're not taught posterior lead placement and looking at posterior MI. That's kind of FREC 5 and onwards. But if that's something that interests you, go back and look at the videos from last summer and have a look at what you would do if you saw ST depression in your anterior leads, okay? Because you would be wanting to rule out a posterior MI, and that means moving the ECG leads. Here's some examples of ST elevation MIs. Okay, this is a nice inferior. You can see here leads 2, 3, and AVF have that kind of stick shape. So, Shannon, good question. They're all on our website. Go to stctrainingsolutions.co.uk, CPD Home, and all of the ECG series are at the bottom of that page. So you can see here leads 2, 3, and AVF, our inferior leads, all have an element of ST elevation. You can see that tick shape. You can see that the QRS complex doesn't finish, and the T wave effectively starts midway down the downward S wave. Okay. So you can also look at the rest of the ECG. You can see that there's a little bit of ST depression in that lateral lead there, also in a bit of V3. Because we've got a diagnostic STEMI here, you wouldn't necessarily then go and put leads on the back of the patient. There's no point because you've already diagnosed the heart attack, you know what's going on. You can see there's a little bit of ST depression again in that lead 1 and a little bit of downward sloping. Good. Other than that, the ECG looks fairly okay. This is something called reciprocal change, which is quite interesting. This QRS complex here, you can see it's mirroring the lead below it. Reciprocal change in AVL is quite characteristic of your inferior heart attacks. Okay, inferior wall heart attacks. Things to look out for there, if you remember from the quiz last week, inferior heart attacks cause bradycardia because the inferior wall is supplied by the right coronary artery. The right coronary artery also supplies the SA node. If the SA node becomes hypoxic, it slows down. So you get sinus bradycardia, often with inferior MI. Here's a question of anterior. Anterior is often known as a tombstone MI because it effectively looks like a tombstone. Your ST segments are very raised here. This is a good 6 or 7 mil of ST elevation here. So you can see there's a little bit in V1, there's lots in V2, even more in V3, lots in V4. So this would definitely be diagnostic of a nice anterior MI. This is a tombstone MI. Looks like a tombstone. If you don't do anything about it, the patient ends up under a tombstone. If you look at other leads here, you can also see a little bit of ST elevation in lead 1, a little bit of ST elevation in lead AVL, and a little bit in V6. That's a premature ventricular complex. You can see bolted on the end there. To answer Gary's question from earlier, can you just see it in lead 2? No, you can see it in all leads. In this case, it's occurred towards the end of this rhythm strip, so it's only visible in V4, V5, and V6, but that is the same premature ventricular complex going off there. Not uncommon in a heart that's having a heart attack. Good. So interesting point there, those of you that have been doing reading around this. So the anterior wall of the heart is supplied by the left anterior descending. The lateral wall of the heart is supplied by the left circumflex artery. So you could suggest here that actually, because there's some lateral involvement here, that perhaps the left main stem is involved. The left main stem is the bit before the left coronary artery splits in two and becomes the anterior descending of the circumflex. And they're really bad. They're really bad. If the whole left side of your heart starts to die, it doesn't beat for very long. So these patients are likely to arrest. All MI patients have the possibility of arresting, but big old lateral and anterior MIs where you've got left main stem involvement, if they don't arrest when it first happens, there's still a very, very high chance of them arresting with you. So that's one to look out for. And then the rarest of them all really is the isolated lateral MIs. You don't see many of those. I think I've only seen 2 or 3 in practice. Lead 1, lead 2, lead AVL, sorry, and a little bit in V5, but you can see that classic shape of the ST elevation here. It looks very different to the anterior wall MI. So the anterior wall MI looking like a tombstone, but the classic ST segment here of the QRS complex doesn't quite finish. The T wave comes out halfway down the downstroke and it gives that kind of thick shape to it. This is something you definitely wouldn't want to miss. But again, quite rare to see just true lateral wall MI on its own. You don't see that often. I'm trying to see whether there is anything else going on. There's probably some posterior wall MI going on as well. If you look here, you've got that ST depression in V1 to V3, which would make me suspicious that if there's ischemia at the front, there could well be infarct at the back. So we would have a look at the posterior trace maybe. But again, you've already diagnosed lateral wall MI. What's the point? Just get going to hospital. Good. Any questions coming in? No, fabulous. Okay, so the other thing I just want to talk about then is T waves. T waves can help you out. So we're talking about other signs of ischemia. Okay, so ST depression is one, T wave inversion is the other. Okay, so there are some different types. You can describe your T waves in loads of different ways. I'm not going to go through all of these tonight. This is way above what you'd need to know for FREC 4, but it's good CPD if ECGs interest you. Normally, normal T wave, as I said last week, looks a bit like a roller coaster. Your S complex finishes, your ST segment's nice and level, and then you get that gentle upslope with a steep decline. So a little bit like a roller coaster shape. Biphasic T waves just basically means it goes up and down. So if it goes up first, that's okay. If it goes down first, that's not so great. You can have notched T waves, you can have broad T waves, you can have flat T waves. All of these mean ischemia generally. Hyperkalemia is too much potassium in the body. That can give you these really big tented T waves. Okay, they look huge and really quite pointy. But this is the one we're looking out for, this kind of deep ischemic T wave. So if you see inverted T waves, T wave inversion is often abbreviated to TWI. So if you see inverted T waves, that can be a sign of ischemia as well. Ischemia meaning the heart not getting enough oxygen. ST depression, T wave inversion, they often come together. I think we had some examples in the last slide. Let me just get backwards. So no, not so much here. We've got definite ST depression, but actually we've got a positive T wave. So not so much in that example, but often they do come together. And something to look at is QT intervals as well. Longer QTs, they look that kind of flat, stretched type shape. So there's a couple of examples on the right-hand side here of biphasic T waves. This is one that goes positive first, then negative. This is one that goes negative first, then positive. Both of these can indicate ischemia, but much more the bottom one is much more associated with ischemic shapes. Again, hopefully that's useful to you. That's to say not part of the FREC full curriculum, but it should hopefully become useful to you in practice. You don't want to be looking at an ECG which is full of ST depression and full of T wave inversions and say that's normal, even though technically it might meet the 6 rules of normal sinus rhythm. That's just it could be, particularly in a patient with chest pain, it could be the beginning of something very serious. So hopefully that's been useful. We're going to have a quiz now. So say it's just over 50 of you. It'd be great if we could get as many of you as possible. So you get okay, fine. Let me just flip the page over. So go to menti.com then. If you want to take part in the quiz, as I say, the prize is 10% off a course of your choosing, and we will honour that on our up and coming FREC 5. So go to menti.com 2040 3003. We've got 8 questions this evening. Unfortunately, once I start the quiz, nobody else can join. So if you do want to get in now, I'll give you a minute to join up. Of course, if you're just along for the teaching, you don't want to take part in the quiz, we're done. So you're more than welcome to disappear. Okay. See how many people want to get in. We're over 30. That's the highest we've had so far. Anyone else want to come along? Give you a minute or two. Okay. Right. Someone's just left, so I'm assuming we've reached peak. Okay. So if everybody's ready, you need to look at your phones. You'll get a question. You'll get 20 seconds to answer. The first person to answer correctly wins. And obviously it goes in order. At the end of the 8 questions, the person that's answered the most correctly, and generally the quickest, will win. That's how it works. So when you're ready, have a look at your phones. What's the ECG show? Great, see how you got on. Brilliant. Everybody got that right. Fantastic. Just about. One went for VF, one went for PVC. So that was atrial fibrillation. You can recognise it's fast irregular and there's a wobbly baseline. That's underlying fibrillation. Let's see who got that the quickest. Matt's not, no. Oh, I mean, everyone was very, very close there. Look at the scores. It's 10 points in the top 10 people. Goodness me, folks. Simon was just okay. No joint fastest. So Simon, Dane, and Amy E all answered at exactly the same time. So I don't think we've ever had that before. Well done, guys. You know your AF. Good. Next question. What does this ECG show? I apologise, the picture's a little bit smaller. Fantastic, well done. So that was an inferior wall MI. We had ST elevation showing in leads 2, 3 and AVF, which is the inferior portion of the ECG. So very well done to 21 of you that got that right. Okay, let's have a little look at who answered that quickest. So don't answer in the chat. If you want to answer, then it's all through the app. You've got that. Shannon's taken the lead. Very well done. Scott, so your name, so I think it only shows the top 10 names. Obviously there's 31 players in there, so if you're not in the top 10, you'll not appear on the screen, but it doesn't mean you're not part of the game. So fantastic. Next question, number 3. What does this ECG show? Well done. Premature ventricular complex, big, broad and bizarre, like my ECG teacher. Excellent, who got that fast? Ooh. Who have we got? Matt was the fastest there, so Croc's in the lead. Okay. Question 4. What does this ECG show? Some really quick answers. Very well done. People are on fire tonight. Excellent, well done, guys, well done. So that was ventricular fibrillation. Ventricular fibrillation is the general discoordinated electrical activity, normally after a big cardiac episode. We got that right in the fastest time. Who was fastest? Matt was fastest again, creeping up the leaderboard. Well done. So Alex, John, Emma, and Matt, there is 36 points between you. So very well done. Some good scores again tonight, really on. Question 5. What is the correct treatment for this rhythm? Fantastic. Asystole. Okay, what do we do with asystole? 2 minutes of CPR and then reassess. Okay. We don't need to check for a pulse. We certainly don't shock asystole. There's no point. And that's they were the options, weren't they? Okay, very well done. 2 minutes of CPR and then reassess. As I say, once again, please don't answer in the chat. It ruins it for others. If you're not taking part in the quiz, then please don't pop them in the chat. Well done, Matt. My goodness, Matt at the top of the leaderboard. You're not second. What's going on? Very well done. That was a quick answer. Fantastic. Okay. Question 6. What's the correct treatment for this rhythm? Ooh, caught a few people out there, didn't it? Okay, so that was VT. So you always check for a pulse and then shock. Okay, So shock and 2 minutes of CPR would be correct for a VF rhythm. You don't need to feel for a pulse in VF, but if it's VT, absolutely check for a pulse and then shock. Once again, please don't put answers in the chat. Okay, lovely. Okay, well done. Who got that right, and who did it the fastest? Okay. I spoke too soon, Matt, didn't I? And yes, history has shown. Alex, well done. Emma, Phil, Eric, St. Elmo, Matt, PJ, Maria. Maria was fastest on the last round. Very well done. Okay. So VT, so Stacey, VT is shockable. It's one of the shockable rhythms, but we feel for a pulse first. That's the only difference between VT and VF. That's absolutely shockable. It was the one that the AEDs get confused by, if you remember. So they can't, because they can't tell whether the patient's got a pulse or not. So often they err on the side of caution, so they don't shock. But you don't see it very often. So question 7, if everyone's ready. A patient presents in cardiac arrest. Oh, hang on. Right, ignore this question. Nobody answered this question. The picture's come up wrong. Okay, the picture is supposed to be of PEA. So if you want to get a correct mark, answer PEA. Where would we be? Oh, it was going too well, wasn't it? I've not had a technological failure this evening. So, but yeah, the photo's wrong. The picture was supposed to be of PEA, not VT. So fine. You are right though. The people that ticked VT, you are right. So ignore that. Ignore that one. We'll strike it from the. Okay, so we can just skip through the leaderboard. And there we go. Fab. Okay. Right. Last question then. All to play for. What does ST depression usually indicate? Fantastic. So ST depression is the opposite of ST elevation. So ST elevation is of course when the ST segment goes up. ST depression is when the ST segment goes down. So it's not normal. It doesn't mean cardiac arrest. It does mean myocardial ischemia. So very well done to the 21 of you that got that right. Let's see who is in the running there. Fantastic. Who wins tonight? Phil wins with 7,078 points. That's really, really high. So very well done, Phil. It was obviously some quick answers there. Phil, and fantastic. Some really good scores there this evening. So hopefully that's been fun. And hopefully you've learned something. Sorry about the picture being wrong. I don't quite know what's happened there. So that's it for this evening, guys. I hope it's been useful for you. As I said, it would be a little bit of a shorter one this evening because there's not a huge amount at FREC 4 level you need to understand about ECGs. But of course, please do go on and do CPD about it. You know, if it's an area of interest to you. As I say, go back and look at our old webinars. We'll be doing more next year. Buy the book, have a read through, get interested in it. I find them fascinating. We'll be back next Wednesday, the 17th of November, for intermediate life support. We'll be talking about cardiac arrest management. So we'll be following on from this quite nicely. It's a theory session. It doesn't count towards your annual requirements as a FREC 4 or FREC 5. So if you do need to do an ILS in face-to-face, obviously we're doing one on the 12th of December. Charlotte's put a link in the chat for you to claim your certificate. We would also be really grateful if you could leave us a review somewhere just to say if you've enjoyed tonight. It does help us get people along for our courses. And of course, we'd love to see you all again and as many people as you can bring with you next week on the 17th of November at 7:30 again. I'll take any questions from the audience. And of course, if you think of something later, then please feel free to drop it to webinars@stctrainingssolutions.co.uk. I'm just going to have a flick through, see if there are any questions I missed just in the last bit there. So you're more than welcome. Everyone's saying thanks and good night. Good night to you. Hopefully see you next week. Thank you for coming along. You're more than welcome. There's links there. I know, absolutely. We weren't getting any technical challenge, and there it was, right at the worst time. More than welcome, guys. Have a great evening, and we hope to see you. Again soon. As I say, I'll take questions from the audience. Oh, hello. Also, just pause.